Hello, I'm Dr. Alfred Garfall, Assistant Professor of Medicine and Director of the Autologous Hematopoietic Stem Cell Transplantation Program at the Hospital of the University of Pennsylvania. Today, I will be discussing the symptoms, risk factors, grading, and potential management strategies of cytokine release syndrome. Cytokine release syndrome, also known as CRS, is a systemic inflammatory response that can be triggered by immunotherapies that activate T cells, such as T cell engaging bispecific antibodies and chimeric antigen receptor T cell therapy, also known as CAR T cell therapy. CRS is characterized by elevated levels of pro inflammatory cytokines. CRS is a potentially life threatening adverse event that can be managed with appropriate targeted interventions and supportive care. CRS symptoms range from mild to severe. Appropriate clinical management can involve early identification of signs and symptoms of CRS. CRS can present with flu-like symptoms, including fever greater than or equal to 100.4 degrees Fahrenheit or 38 degrees Celsius, fatigue, headache, rash, diarrhea, arthralgia, and myalgia. In some cases, patients may experience more severe symptoms. Severe, life-threatening manifestations of CRS may include hypotension, hypoxia, seizures, disseminated intravascular coagulation, multi-organ dysfunction, and potential fatality. Generally, the onset of CRS occurs early, within the first few days following therapy administration. However, the timing of CRS may vary depending on the type of T-cell engaging therapy and characteristics of the particular product. For example, with CAR T-cell therapy, CRS may occur within 1 day of infusion or with later onset, typically within 2 weeks of administration, but rarely even later. With bispecific antibodies, the route of administration and dosing scheme can affect the onset of CRS. Subcutaneous administration of bispecific antibodies and step-up dosing may delay onset by a few days. Certain patients may be at greater risk for experiencing these severe manifestations of CRS. Some clinical factors that can influence the severity of CRS include patient-related factors such as age, comorbidities, pre-existing inflammatory conditions, and thrombocytopenia prior to lymphodepletion, for example, with CAR T-cell therapy. Therapy-related factors such as therapy modality, administration dosing schedule, strength of T-cell activation, and degree of T-cell expansion. And disease-related factors including disease type and high tumor burden. CRS has clinical signs similar to those of sepsis. It is important to consider infection as an alternative or coexisting diagnosis. Rarely, bispecific antibody or CAR T-cell therapy can be associated with hemophagocytic lymphohistiocytosis, which can occur simultaneously with, separately from, or in the absence of CRS, and has distinct management guidelines. Appropriate differential diagnosis should be considered for CRS diagnosis and management. Furthermore, neurotoxicity, including ICANS, is an additional risk that may be associated with CRS. Neurotoxicities often occur in association with CRS, but can also occur in the absence of CRS. Symptoms of ICANS may include tremor, encephalopathy, aphasia, seizure, cerebral edema, and others. To assist with CRS identification and management, multiple grading criteria have been defined, including CTCAE, CARTOX, and MSKCC guidelines. The ASTCT is a broadly used grading system that harmonizes other guidelines into a consensus framework. Using this framework, grade 1 CRS, shown here, presents only with a fever of greater than or equal to 100.4 degrees Fahrenheit or 38 degrees Celsius. In addition to fever, grade 2 CRS can present with hypotension that does not require vasopressors and/or hypoxia that requires low-flow nasal cannula or blow-by. For grade 3 CRS, fever can present with hypotension that requires one vasopressor with or without vasopressin, and/or hypoxia that requires a high-flow nasal cannula, face mask, non-rebreather mask, or Venturi mask. Lastly, for grade 4 CRS, fever can present with hypotension that requires more than one vasopressor, excluding vasopressin, and/or hypoxia that requires positive pressure, such as CPAP, BiPAP, intubation, and mechanical ventilation. Strategies for mitigation and monitoring are important for reducing risks associated with CRS. For prevention of CRS associated with T-cell engaging therapies, clinical trials include the following medications for consideration depending on therapy modality: corticosteroids, antipyretics, antihistamines, and antimicrobials. Currently, guidelines for prophylaxis are not established, and various strategies are being investigated. However, some guidance may be provided in the prescribing information and can be product specific, such as the use of antipyretics, corticosteroids, and step-up dosing for bispecific antibodies. Patients should be monitored for early signs such as fever and symptoms indicative of CRS, including laboratory testing for disseminated intravascular coagulation, hematology parameters, as well as pulmonary, cardiac, renal, and hepatic function. When monitoring patient symptoms, differential diagnosis should be considered. In the case of other clinical manifestations such as infections, proper diagnostic testing such as blood and urine cultures, basic liver function testing, chest x-ray, nasal viral swabs to test for the presence of infection, and neutropenia evaluation should be conducted. Subsequent management strategies may need to be adjusted accordingly with the addition of antibiotics to account for infections. CRS management is evaluated on a case-by-case basis for each patient. Generally, patient-related factors that should be considered include tumor burden, comorbidities that could hinder the patient's ability to endure CRS complications, and patient access to supportive care at the first sign of symptoms. Pharmacologic management strategies for CRS are described in established guidelines. Currently, there are CRS management guidelines available for immunotherapies, for example, bispecific antibodies and CAR T-cell therapy. In general, for the management of cytokine release syndrome, consider the administration of anti-IL-6 receptor medications and corticosteroids per institutional guidelines. For more comprehensive guidance on supportive care related to CRS management, refer to the institutional guidelines and established guidelines such as ASCO, CARTOX, EMASMART, NCCN, and CITSI. It is important to monitor patient symptoms and assess CRS grading. There are different management strategies based on CRS grading and in accordance with institutional and established guidelines, including the administration of anti-IL-6 receptor therapy and corticosteroids. In general, recommendations for grade 1 CRS management include supportive care, with the addition of anti-IL-6 receptor therapy being considered for persistent fever. For grade 2 CRS, anti-IL-6 receptor therapies may be used to manage fever, hypotension, and hypoxia if indicated. And for patients at high risk of developing grade 3 or 4 CRS, corticosteroids can be considered. For grades 3 and 4, both anti-IL-6 receptor therapy and corticosteroids should be used for the management of CRS and associated organ toxicities. Management of CRS can vary by practice, and generally, anti-IL-6 receptor therapies are preferred due to their efficacy and their mechanism of action that likely does not significantly impair T-cell function. Corticosteroids are considered across CRS grades 2 through 4. In clinical experience, the use of anti-IL-6 receptor therapy for grade 1 CRS has become more common, particularly with bispecific antibodies, to allow for timely completion of the step-up bispecific antibody dose sequence, but practice varies by product and institutional practices. From my own clinical perspective, anti-IL-6 receptor therapy is preferred at grade 1 CRS with persistent fever. For grade 2 CRS, start with a single dose of anti-IL-6 receptor therapy and evaluate for the addition of steroids if CRS does not promptly resolve. For grades 3 or higher CRS, consider the administration of anti-IL-6 receptor therapy and steroids from the start. If there is no clinical improvement within a few hours of dosing anti-IL-6 receptor therapy, consider repeat dosing, as the label says redosing can occur 8 hours after the first dose. For redosing anti-IL-6 receptor therapy so soon after the first dose, consider adding additional measures such as corticosteroids. Finally, there are many operational considerations for monitoring and managing CRS in patients being treated with T-cell engaging therapies. These include the potential requirement of clinical interventions such as inpatient monitoring, anti-IL-6 receptor therapy availability, ICU availability, and specific site training on CRS for physicians. The implementation of a dedicated clinical and safety plan for monitoring patients receiving therapies in both outpatient and inpatient settings, other logistical considerations for transitioning patients between care settings, such as outpatient to inpatient and inpatient to outpatient transitions, and educating patients and caregivers on signs and symptoms of CRS. Overall, features and limitations of administration sites should be considered in addition to CRS grading and patient risk factors in order to provide optimal care. To learn more about characterization and general management of adverse events associated with anti-multiple myeloma treatments, please visit janssenscience.com.